All right, chapter 21, we're going to be talking about poisoning and overdose emergencies. We'll run through some of that and get you an idea of what kind of overdoses you might be dealing with and how to treat those, and what kind of poisonings we might be dealing with, whether it's kids or elderly or just any population we could hit on. So, poison is any substance that can harm the body. The harm it can cause can result in a medical emergency. Common poisonings, we often see medication poisonings. You can have cosmetic poisonings, pesticides, plants, foods. There can be all kinds of different poisonings that you might run into. A poisoning is a harm to body based on nature of poison, its concentration, the route of entry, the patient's age, weight, and health. So it can cover a multitude of things. It can cause damage to skin and tissues, it can cause suffocation. It can also cause some localized or systemic damage to body systems. So body systems we've been talking about a lot in our medical assessments. It can, depending on what you have, you can have the skin can be damaged. There could be the nervous system can be damaged. There could be all kinds of different things. So it just depends on what type of poisoning we're talking about. So they're classified by route. They can be ingested, they can be injected, they can be absorbed, or they can be inhaled. So different ways we can get a poisoning, right? So if you're working on a farm and there's you're working with a gas, or you're working with some fertilizer and that leaks out, right? That may be inhaled, or you get something on your skin that can be absorbed. Okay. So EMT's own home and squad buildings should be child-proofed, right? Anywhere where we have kids should be pretty much child-proof, right? We need to have poisoning prevention information with members of the public. We should be doing information on that as best as we can to educate the public against about child-proofing homes and whatnot. So once again, routes of entry, just showing you some different examples there. Our biggest injection that we see is obviously drugs. That happens quite often. We run into those quite a bit, and they continue to be on an uptick. So see a lot of that. But all these other things can happen, right? Ingestion normally is accidental, but sometimes people do it on purpose as well. So, like I said, children accidentally eat or drink a toxic substance. If with adults, often an accidental or deliberate medication overdose. Not often we have them drinking toxic substances, but a lot of times they do have an accidental or intentional medication. So you might say, well, how does somebody have an accidental? You have your elderly that have their daily pills, so they forget what day it is. They take the pills twice. That happens. Or you have somebody who's depressed and they think that the best way to go is to take a bottle of Tylenol. Well, it doesn't kill them, but it does do a lot of body system damage. So what substance was involved? We're trying to figure out what we're dealing with here. What kind of medication or substance are we dealing with? And the patient needs to go to the hospital. How long ago did this happen? Like we do with all other things, how long did it take? And then we need to notify ER personnel for appropriate testing and treatment. And number one thing we can do in the ambulance, whether you're an EMT, a paramedic, or whoever, is call poison control. Calling poison control ahead of time gives you a wealth of information, right? We don't know 100% about everybody, every single thing. We're never going to know every treatment for every poisoning and overdose that can happen. So the best thing we can do is call poison control. Get them on board, get their information, and then we have the whole world of information at our fingertips, and we can give that to the hospital, because the hospital has to do the same thing. They're required to call poison control. So if you've already started it, one of the questions when you call poison control is, what hospital are you going to? So then we can get them to that hospital. That information is going to get to the hospital. Makes you a better EMT. It's better patient care for your patient, and the hospital is one step ahead of where they need to be. So it really benefits the whole system. So how much was ingested? Sometimes with pills, we're going to count pills missing from a pill bottle. When was it filled? Okay, and once we figure out when was it filled, how many are missing for that time frame doesn't match what should be matching or should be missing. Over how long of a time did the ingestion occur? So, if this was 48 hours ago and we're just not hearing about it, our treatment's going to be very much supportive care. It's just getting into the hospital to get checked out, if they even need to go. However, if it was, we took 50 pills in the last 5 minutes, those pills haven't had time to kick in. So now all of a sudden we're looking at a serious problem that's coming. They may be okay right now, they may be up here right now, staying at a certain level of consciousness and a certain level of stability, but those pills haven't all kicked in and they're going to start to quickly go down the hill. So we have to prepare for that. We have to be ready for that and know and understand that there's challenges coming. Okay? So what interventions have been taken? What treatments have been given? And are there any treatments indicated on the actual label of the container? Sometimes these medications will have treatments listed. Have home remedies been given? Especially some things, you know, syrup, ibuprofen, they may be trying to force vomiting. They may be sticking their finger down their throat. Although that's kind of a strange home remedy, it may be counted as one, right? What is the patient's weight? And it may affect the rate of onset of the toxic effects on how fast this stuff kicks in. Has the patient experienced nausea and vomiting? How much do they actually have in their system? Have they vomited it all up in the first 5 minutes and they don't really have that much in their system? Or, you know, they haven't vomited anything, or they just vomited a little bit, right? So it just depends. Food poisoning can be caused by improperly handled or prepared foods. Almost everybody has experienced this at one point or time in their life. It can occur within hours of ingestion or several, a couple days later. And it can get people pretty sick. They can look pretty rough with food poisoning. Okay? Activated charcoal. It's one of the medications we talked about in chapter 16. Activated charcoal works through absorption, allowing substance to attach to its surface. It is not an antidote. It prevents or reduces the amount of poison absorbed by the body. All it's trying to do is get in there and suck up what it can, okay? And it's not going to prevent the whole situation. Many poisons, but not all, are absorbed by activated charcoal, so it doesn't work on everything. It works on some things. And medical direction is a good way to find out what it can work on and what it can't, right? We don't know all that stuff, and we're not required to know all that stuff. Sometimes it's okay to accept that some things we have to call for help on. So traditionally, cerebral ibuprofen was preferred treatment for poisoning. It induced vomiting in most people with one dose. However, it has the potential to make patient aspirate and only removes less than 1/3 of our stomach contents. So the other 2/3 of poisoning are just chilling in there, right? So the adult patient should drink 1 to 2 glasses of water or milk. That's dilution, trying to knock it down a little bit. Children should drink 1/2 to 1 full glass of water or milk. Water may slow absorption, but milk may smooth an upset stomach. Okay? It's frequently advised for patients who, as determined by medical direction, do not need transport. So this is not going to be something we recommend on our own. This is going to be something if we talk to a poison control or medical direction, they say, no, that's really not enough of anything to cause them to have to go to the hospital. They're going to be just fine. They can stay at home. Mom and dad just needs to watch them. Maybe recommend them they drink some milk to keep them calm or keep their stomach happy, that kind of thing. So antidotes, thought of as a substance that will neutralize the poison or its effects. There's very few genuine antidotes that exist that have been proven to work, right? Narcan directly reverses narcotic suppressants. We talked about that once again in chapter 16. Narcan is kind of our miracle drug for opiate overdoses, right? So we have a patient who we get to, maybe they're seizing, maybe they're unconscious, maybe they're barely breathing. We're going to get there, we're going to see them, and then our medics can give Narcan in our system, and it really it completely reverses it. It's quite impressive. But like all drugs, Narcan now, we may have to redose, right? And they wear off. We have to monitor our patient, reassess. And then we may have to actually give another dose of Narcan if it starts to come back to effect. Because all it's doing is blocking those receptors for that time period. Once that medication wears off, that half-life wears off, there it is again. It's ready to go. The opioid's still there. So ingested poisons, when a patient has ingested a poison, it provides another reason to avoid mouth-to-mouth contact. You provide ventilation through a pocket face mask. Obviously, we never want to do mouth-to-mouth if we can avoid it. We want to use any and all other means to avoid contracting whatever that patient may have ingested and or may have themselves as a disease or whatever. So we need to call medical direction on scene or route to the hospital. We're talking about this. Call on poison control, making sure that they're aware of what this patient's ingested or injected or however they've got it. They're going to give us the correct idea on what to do. In this case, administer activated charcoal You can put it in an opaque cup that has a lid with a hole for straw. That way they don't have to look at it because it kind of looks a little nasty. But in our system, we don't use activated charcoal. You may in whatever system you go to. And then we have to position the patient for vomiting and sedate the vomitus and have suction equipment available. So it's going to induce vomiting, and so we need to be aware of that and be ready for them to puke, okay? So think about your home. Is it safe for small children? Is your home ready to go? I know my home wasn't at first. We have 2 kids, and so I've eventually got all the electrical cover outlets on there. I've got my medicine cabinets pretty much locked up. But is your home safe? Is your workplace safe if you got kids there? That stuff is important. So inhaled poisons, common types, and this is what I was talking about a little bit earlier: carbon monoxide, ammonia, chlorine gas, agriculture. I was trying to say anhydrous ammonia earlier, but I couldn't come to my brain. If you're working on a farm, you might be using anhydrous. If it leaks out in high quantities, it's definitely a respiratory gas that can take away all respiratory drive. So carbon dioxide as well. If you're in an oxygen deficient environment, these can all be inhaled poisons. So first thing for us is always scene safety. Is you got to approach with caution, and there's plenty of videos out there of responders responding in without taking that cautionary tale and making sure it was completely safe and then them going down. If we're not trained or equipped to enter that kind of atmosphere, which as EMTs we aren't unless we have our fire guys, then we should not enter that area. So these guys are wearing full respiratory protection. They're able to go into a poisoning environment and a respiratory concern environment because they have the correct PPE. So there's different signs and symptoms, maybe difficulty breathing, maybe chest pain, coughing, hoarseness, dizziness, headache, confusion, altered mental status, seizures. They may just be completely unresponsive on the ground. You may think you're going to a cardiac response, cardiac arrest, and if you don't pay attention to the scene safety and the signs up, you may not realize that you're going into an inhalation hazard area, and that's why they're down. So you need to really pay attention and make sure you've done a good scene signs up. So what substance was involved? What is the exact name of it? When did this occur? How long ago was it? Has anybody done anything? Has anything helped? Has the patient been removed from the immediate hazard area, or are they still in it breathing? Did someone ventilate the area? Is it still a risk for us? And what is the patient experiencing? We have to move the patient from the unsafe area. That may be the first thing that has to happen. We have to get the area safe or remove the patient from the unsafe area if we're trained and able to do so. If not, we have to wait for people that are trained and able to do so. Then we're going to work through our ABCs. We're going to detect and treat live threats, all right? So they're going to have an airway problem or a breathing problem, pretty much guaranteed with an inhalation injury. So are they breathing? Is their airway open? If not, we're going to have to fix those things. So we're going to administer high concentration oxygen, and as oxygen's the first priority. You're going to see some test questions this week about different conditions and what to administer first, okay? Oh, well, we do airway breathing circulation unless they have a massive hemorrhage. So if I'm having crushing chest pain, should I give oxygen, which deals with airway and breathing, or should I give aspirin first? I would give oxygen first because you're airway, breathing, and then circulation, okay? So oxygen first. What's more important for that condition? More important for a chest pain is probably the aspirin, but we're going in a certain order, okay? So just know that if you see that on a test question, that's the order. We want to transport with all containers, bottles, and labels, and perform reassessment and route. Carbon monoxide is a colorless, odorless, tasteless gas created by combustion. It can be caused by improper venting of fireplaces, portable heaters, generators, water heaters, all that good stuff. Common cause of death during winter and power outages, right? This happens quite a bit. Signs and symptoms of CO, right? Headache, especially a band around the head. They feel like there's a tightness, dizziness, difficulty breathing, nausea, cyanosis, altered mental status, and in severe cases, unconsciousness. Okay? So there's specialized monitors that fire trucks carry. We don't carry them. Some ambulance departments do. That it will detect the presence of CO in the environment. Patient may begin to feel better shortly after being removed. We want to administer 100% oxygen via non-rebreather, of course. We're going to transport to the hospital. It takes time to wash out CO from the bloodstream, so the more oxygen we load up, the better off we are. And the tricky part for us is their pulse ox is going to show 100%. Okay, their pulse ox, the SpO2 monitor is going to show 100%. It cannot detect the difference, right? So it's going to know it's going to show 100%. You need to give them oxygen anyway to wash that out. Smoke inhalation. Smoke from burning materials can contain poisonous and toxic substances, including CO, ammonia, chlorine, and cyanide. The substance can irritate the skin and eyes, cause damage to the lungs. It can even progress to cardiac arrest. This is where we see firefighters that have been at a fire, they die the next night, or that night, or the next day. So they've had a buildup of poisonous, toxic substances in their system, and then they end up passing the next day. Once again, some symptoms, signs. We're going to have difficulty breathing, coughing. They might have a smoky or chemical smell in their breath. They might have black residue in their mouth, nose, or sputum. And they're going to have singed nasal or facial hairs. Pretty good sign if you see any of these singed nasal hairs that you're going to have an airway compromise. Okay, it may not be compromised yet, but you're going to have one coming. So you need to be meeting with an ALS intercept or getting to a facility quickly so that they can treat that appropriately. So if you see facial marks, you see black singed hairs, any of that stuff, you need to get them to a hospital quickly or get to an ALS intercept so that they can take care of airway interventions. Move the patient to a safe airway, assess the patient, maintain the airway, provide high concentration O2. Airway burns may lead to swelling, that's what I'm talking about, right? So we need to get them to an ALS intercept as quick as possible. Detergent suicides, the newer method of suicide, started in Japan, is becoming more and more common in the United States. It's a mix of two easily obtained chemicals to release toxic hydrogen sulfide gas. Common release inside enclosed space such as a car or closet. We've seen a few of these, and they're not very fun. So, the exposure to the fumes could injure us, so we need to be careful. We need to make sure that we recognize clues and signs. There's a lot of times they leave a warning note because they're not trying to hurt other people. They just want to take their own life. And depending on the situation, fire or hazmat may need to enter first with respiratory protection before we go in, because that could be a respiratory hazard for us, obviously. Absorbed poisons can be absorbed through the skin, may or may not cause damage to the skin, and the patient may require decontamination prior to treatment. So once again, we're on our assessment, we're asking what substance, when, how much, how long, what interventions, what effects has it had, what's it doing to my patient? Those are things we need to know. We're going to assess for our ABCs, okay? See if we can get them out of the area or get the stuff off of them. So brushing off powder, careful with that. You need to be wearing an N95 mask because you can make it airborne depending on what it is. Irrigating with clean water for at least 20 minutes after it's brushed off and during transport. We're going to transport with all containers, bottles, and labels from the substance. We're going to perform reassessments en route. Most common injected poisonings, illicit drugs pretty much, and then venom of snakes and insects, right? Man, do not like them snakes. So hopefully we don't have to deal with that. Poison control centers, once again, excellent resource, going to give us a lot of information, going to be able to help us make the call on what we need to do. So alcohol and substance abuse, we deal with quite a bit of this as well. We see a lot of patients who have alcohol intoxication, right? So with that being said, many patients whose conditions are caused either directly or indirectly by alcohol or substance abuse. Abuse of alcohol and other drugs crosses all geographic and economic boundaries. This is one you'll find quite a bit. You may come into this and think, oh, just these people in this area are doing drugs. Drugs affect every portion. If I asked who in the classroom knows somebody who has used drugs or knows of someone who has used drugs, probably everybody's going to raise their hand. Drugs affects all socioeconomic classes. So alcohol is the same way. Alcohol intoxication hits everybody. So we have to just know that it's not anything we're going to judge people on. It hits all areas. We're just here to treat them and take care of them. So alcohol abuse has some potent effects on the central nervous system. It can be very addictive. Emergencies result from recent consumption or years of abuse. We have to treat patients as any others, and abuse can lead to worsen other medical conditions. They can start to get sicker in other areas. A lot of these people are very malnourished because all they're doing is drinking alcohol, so we have to treat for that as well. A lot of times these patients can be impaired or combative. Sometimes we have to sedate these patients before we can get them taken care of. A lot of times we have law enforcement there to help us with that. So some signs and symptoms: they're going to have alcohol on their breath, swaying or unsteady on their feet, slurred, rambling speech. A lot of times they've urinated themselves. They may be flushed or complaining of being very warm. Nausea and vomiting, obviously. Poor coordination. The biggest thing is slowed reaction time. Okay, they may have some blurred vision, confusion, hallucinations, lack of memory, or altered mental status. So withdraw. It's abrupt cessation of drinking may cause some alcoholics to suffer from delirium or DTs, delirium tremens or DTs. This can be serious, resulting in tremors, hallucinations, and even seizures. These folks are sick, okay? They're going through withdrawals, and it is a painful process to watch. Like I said, they may be seizing quite a bit. We need to treat these patients and try to make them as comfortable as possible. So, you're going to see confusion, restlessness, unusual behavior, hallucinations, and gross tremors in the hands. They may have profuse sweating, seizures, hypertension, and tachycardia. Once again, on assessing them, it may mimic alcohol intoxication, but they may tell you they haven't drank in days. Intoxicated patients may also have medical problems, like we talked about. We've got to do a full assessment no matter what, right? Just what if they were drunk and they fell and hit their head, and they're not actually confused because they're drunk, they're confused because they fell and hit their head and they have a brain injury. So we've got to do a full assessment to try to determine what's going on. We often see vomit. We need to have suction ready, be alert for that, be ready to go for that. We've got to be alert for changes in mental status. If they start to crash, we might have to take control of the airway or do something more difficult, right? We've got to treat for shock, keep them warm, put oxygen on them as necessary, stay alert for seizures, and get them to the hospital. So substance abuse in general, I'm not talking about alcohol now, just moving on a little bit. Any chemical substance taken for other than therapeutic medical reasons. It can include uppers, downers, narcotics, hallucinogens, and volatile chemicals. Here's some substances that are often abused or used. A whole bunch of stuff in there. So uppers are stimulants that affect the nervous system. We've got cocaine, amphetamines. These can be snorted, smoked, or injected. A lot of times these folks are going to be excited. They're going to be really moving fast. They may be restless. They're going to be a little hypertensive, hyperthermic. They may not sleep for days. They're going to be sweating. They're pretty intense. Downers are going to affect the central nervous system. They're going to be depressants, barbiturates, roofies, GHB, make people sluggish, have poor coordination, decreased pulse and respirations. You can die on pretty much all this stuff. Narcotics used to relieve pain or help with sleep. There are opiates, heroin, codeine, morphine, oxycontin, oxycodone, all fall in this category. Only problem is they're starting to mix narcotics, starting to mix uppers and downers. Well, they're not starting to. They've been mixing uppers and downers and opiates and all these things, so it becomes harder for us to treat. Signs and symptoms of some narcotics: reduced rate of pulse and rate and depth of breathing. They'll be lethargic. They're going to have pinpoint pupils. What I mean by pinpoint pupils, when you're assessing the pupil, it's just going to be a little dot, right? Not very big at all. It's generally a very good sign that we're dealing with an opiate. Okay. Profuse sweating, could even be in a coma, could not be breathing, could be in cardiac arrest. Okay. Hallucinogens. Creating an intense state of excitement and distorted perception. LSD, PCP, XTC, Flocka, it's a hallucinogen. Signs and symptoms: rapid pulse, dilated pupils, flushed face, and they are going to be seeing or hearing things. Some volatile chemicals produce vapors that are inhaled. It gives an initial rush. Can act as a CNS depressant. Okay. They may be dazed, disoriented, may develop a coma, swollen membranes in the nose or mouth, that numb, tingling feeling inside the head, and they may have changes in heart rhythm. So big one we always see is huffing. Okay, they're breathing in the fumes or bagging the fumes up and then breathing them in. You can tell he's a little diaphoretic, not looking too good. So once again, patient assessment may be a little difficult. Patient's level of consciousness we need to assess. We may have to they may have taken more than one type of drug, which is always a challenge for us, trying to hone that in and figure out what they've taken, what they haven't. Patient may be uncooperative or combative. Some of these patients don't want treatment because they know you're going to take their high away, and so that's a challenge. We got to be aware of needles. Needles can be anywhere, okay? Just because there's kids walking around doesn't mean there's not needles laying out. So we have to be aware of that and watch ourselves, make sure we're safe. Nobody wants to get stuck with a dirty needle. These patients can have airway problems or respiratory distress. We should provide oxygen and assist respirations as needed, and we should treat for shock. We need to talk to the patient to keep them calm and cooperative. We got to perform a physical exam and look for evidence of injection sites, track marks. Sometimes they'll still be bleeding depending on what they took. Sometimes you'll get a fresh site that is literally still bleeding and they just got way too much of something. We need to transport as soon as possible, contact medical control or poison control as soon as possible. We're going to do a reassessment with monitoring vital signs, and we're going to continue to reassure the patient throughout all phases of care. A little review. We're going to do our primary assessment, treat life threats, administer oxygen, go from there. Okay, we're going to consult medical direction, contact poison control whenever we need to. Reassess patient care and route, transport as fast as we can to as fast as safely possible to the closest local facility. Our safety is always our #1 priority, so we don't want to get ourselves in a situation where we could get poisoned, we could get in a bad way. If we need law enforcement, we need to have them there, but we don't want to get ourselves in a dangerous situation. Okay. We should be transporting all these patients, getting them checked out, and going from there. Alcohol is a big thing. We see that a lot, like we talked about. Yeah. All right. So make sure as you're going through watching these that you're taking a lot of time on these chapters that we haven't hit in class, so that you are ready for the test that's coming up. Thanks, and I'll see you guys Wednesday.